Going to adolescent dysmenorrhea. Dysmenorrhea is painful menstrual cramps of uterine origin occurring just before or during menstruation. And we all know it is divided into primary dysmenorrhea, where there is no identifiable pelvic pathology. Typically, this begins in adolescents within 6 to 12 months of menarche, when the cycles become ovulatory. Then the other type of dysmenorrhea is secondary dysmenorrhea, that is usually due to some underlying pelvic pathology like endometriosis or Mullerian abnormalities. So why is it important in adolescent? Why it matters? Because it is affecting 70 to 90% of menstruating adolescents. It is a leading cause of school absenteeism, missed sports, and psychosocial stress. Often, dysmenorrhea is underreported and normalized due to stigma or lack of awareness. Adolescents with dysmenorrhea report a reduced academic performance, poor mental health, disrupted peer and family relationships. Both Foxy and FIGO and other organizations advocate integrating menstrual health in school health programs. Early recognition and management of dysmenorrhea can prevent years of suffering and improve quality of life. This was mentioned in the Foxy Adolescent Health Committee opinion. Then coming to classification and pathophysiology, there is primary dysmenorrhea. It is caused by prostaglandin F2 alpha induced uterine contractions and ischemia, and the cyclical pain starting 6 to 12 months after menarche. The secondary dysmenorrhea is due to structural and functional reproductive tract disorders. Here, the pain starts with menarche or worsens over time and may have irregular bleeding and dyspareunia in case the adolescent is sexually active. Next, please. So how do we evaluate these patients? The essential questions to ask in history. What is the onset of pain in relation to menarche? Pain timing, is it premenstrual or throughout the cycle? Severity and duration of pain, does the girl have to miss school? What are the associated symptoms like nausea, headache, mood changes? And as ma'am just said, nausea can be sometimes associated with endometriosis. Response to, in case the patient has already come with after taking some medicines, then was there some response to the painkillers and hormonal therapy? Then menstrual cycle regularity and flow. Is there any family history of endometriosis? The Foxy and RCOG guidelines emphasize menstrual diaries for pattern recognition. Next, please. So the pain usually begins just before at the start of menstruation. Common symptoms are lower abdominal cramps, backache, thigh pain, nausea, headache, fatigue. The pain peaks in the first 1 to 2 days of menstruation. This is in the primary dysmenorrhea. And in the secondary dysmenorrhea, the pain may begin earlier or last longer. So what does the Foxy guidelines for, how do they say to manage these patients? It is a stepwise non-invasive management initially. Clinical diagnosis in most adolescents with a typical history of primary dysmenorrhea. As I just mentioned, there is a cyclical lower abdominal pain which starts 6 to 12 months after menarche. There are no other systemic symptoms, and usually these patients would respond to the NSAIDs and hormonal therapy. So Foxy says no tests are required initially. So when do we investigate and what investigations to be done? So we should only investigate in case the symptoms are atypical or refractory. So if the pain begins at menarche and is severe and over time it is worsening, and there is no response after 3 to 6 months of NSAIDs and hormones, then we should consider further evaluation. Next, please. So what should be the investigations? Start with the non-invasive imaging, that is pelvic ultrasound, either transabdominal or transrectal, as these girls are generally sexually inactive. This is done to detect obstructive anomalies, endometrioma, or uterine malformations. And of course, we would like to avoid a PB examination in these patients. What about the advanced imaging? We reserve the advanced imaging, and MRI is only done when ultrasound is inconclusive, there is a strong suspicion of Mullerian abnormalities or deeply infiltrating endometriosis is suspected by us. Laparoscopy is the last resort, as ma'am said, only for persistent debilitating pain, suspected endometriosis or pelvic pathology not seen on imaging. This approach ensures that the adolescents are not subjected to invasive procedures prematurely, thus reducing both physical and psychological burden. Next, please. So going to the management, I'll just run through this because ma'am has already said. What is the goal? To relieve symptoms, restore function, and address the underlying causes. The first line for primary dysmenorrhea is the non-steroidal NS. The mefenamic acid is given at a lower dose as compared to endometriosis patients, 250 to 500 milligram thrice a day. Ibuprofen, naproxen, and diclofenac are also effective. And the medicine should be started just at the onset of periods or 1 or 2 days before and continued for 2 to 3 days or until pain subsides. Going to the important part here is we would like to do patient education and the education of the parents, explain the cycle physiology and when the pain is considered to be abnormal, address myths and stigma, involve both adolescent and her parents, encourage use of menstrual tracking apps and diaries, and Foxy promotes school-based menstrual education programs. Next, please. So lifestyle and along with the painkillers that we would give at the initial time when the patient comes, these are the additional factors that have to be done. The exercise regularly, aerobic exercises, yoga. This improves pelvic circulation and pain threshold. Balanced diet should be encouraged. Omega-3 fatty acids, magnesium, and vitamin B should be given. Limit intake of caffeine, sugar, and junk food. Heat therapy like hot water bag. Sleep hygiene and stress management. Foxy emphasizes menstrual health as part of adolescent well-being. Next, please. So in this slide, you can see what are the ways to fight through dysmenorrhea. There's a girl who's walking. She's using the hot water bottle. Hydration should be maintained. Some amount of meditation and yoga is being done. Go on to the next. And these are the simple yoga poses that help to relieve the menstrual cramps. So when should we give hormonal therapy? They should be given when the NSAIDs have failed or are inadequate. The combined oral contraceptives suppress ovulation and reduce endometrial prostaglandins. Usually we would be giving monophasic low-dose pills. A continuous or cyclical regime, ma'am has explained well in detail. Cyclical progesterones can be used as alternatives, and usually in these patients, LNG IUS is not used because they are young girls and are not sexually active. When to suspect an underlying pathology? So if there are no response to the painkillers or hormonal therapy for 3 to 6 cycles, onset of pain has been with menarche and is progressively worsening, non-cyclical pelvic pain, abnormal bleeding, dyspareunia, urinary or bowel symptoms, and if there is a family history of endometriosis or congenital abnormalities, then these would be red flags and we would consider secondary dysmenorrhea and obviously then take up the patient for further investigations and management. So once we have started our patient on lifestyle management, exercise, all the painkillers or the COCs, what is the further management? Validate symptoms and avoid dismissing the patient's complaints as just dramabazi. That is what we should be avoiding. Explain the treatment rationale. Promote menstrual tracking. School has a lot of role to play in helping the adolescent with her dysmenorrhea. Discuss with the patient and call her to reassess earlier, initially in the 2 to 3 months, and then if things are settled, then every 6 months. Every painful period is not normal. Empower our teens to seek help. Next, please. So what do in the next 2 slides, I'll just share with you what are the latest Foxy guidelines on lifestyle, education, and the management. So Foxy emphasizes menstrual literacy to be given in schools and clinics, It encourages regular aerobic exercise, yoga, balanced diet, sleep hygiene, and supports school. And it says that in case the girl is having a lot of problem, then a doctor, the gynecologist, should give her a school note saying that either school absent, she has to absent herself from school, that should be allowed, or to avoid certain activities, or maybe sports activities on certain days, that should be allowed. And the girl should be, in case there's an exam or something, no stress should be caused to her. And involve the parents in destigmatizing menstrual health. Next, please. The other FOXY guidelines regarding the management, of course, it says the first line are the painkillers, which should be started 1 to 2 days before menstruation. The second line are the hormonal therapy with COCs and progestins. Stepwise non-invasive evaluation. Start with history, tracking of menses, and minimal imaging. Consider pelvic ultrasound only in the presence of the red flags that I mentioned before. Refer if symptoms persist beyond 3 to 6 months of treatment. So, as I went through the guidelines of the other organizations, what were the key differences and what were the same things? FOXY is most proactive in promoting menstrual literacy at community and school level in India, aligning with adolescent health policies. ACOG uniquely incorporates HEAD's psychosocial screening and emphasizes menstrual diaries as a diagnostic adjunct. I'll just explain the HEAD's thing. I found this to be new. NICE and RCOG guidelines focus mostly on a conservative approach, minimal investigations, and mental health support. But see this, all reiterate, do not delay diagnosis of adolescent endometriosis, and they all advocate for early use of ultrasound MRI when required. So going to the HEADS assessment, which HEADS is a mnemonic where age, these are the questions that we should be asking, the kind of questions we should be asking for assessing the patient mentally. The H stands for home. So we could ask questions like, who supports you during periods? Is it easy to talk about menstruation at home? For education, do you miss school due to period pain? Does pain affect your exams or classes? Then going on to A stands for activities. Have you stopped playing or socializing during periods? Drugs. What medicines or remedies do you take? Do you use them without advice of the doctor? Then sexuality. Have you had any sexual activity? And in that case, have you noticed any unusual discharge or pain during intercourse? Then, of course, assessing the depression and the mental status of the patient. Does the pain affect your mood? Do you feel low or anxious during periods? So what can be managed at our level, and when should we refer our patients? At our level, we should be able to optimize the pain control by giving the painkillers and COCs, educate about menstrual health, address the absenteeism with school notes, counsel on healthy coping strategies. When should we refer to a psychologist or a psychiatrist? When we think that there is some symptoms of clinical depression, self-harm risk, sexual abuse or trauma is suspected, family dysfunction or psychosomatic disorders, and severe anxiety requiring mental health support. The other thing I found in ACOG, of course, the other guidelines also advocate this, but this is saying that there is to use the artificial intelligence, and there are so many apps that are available, apps like Clue, Flow, Spot On, to assess menstrual cycle, pain, mood, the flow of the cycle regularity. And so now I'm going on to the various 3-4 slides which are going which tell us the myths that are very common amongst the parents of our patients. Myth: period pain is never regular, is normal. All girls must tolerate it. The reality is that when mild discomfort is, while it is common, pain that disrupts daily life is not normal and should be evaluated, treated. Ignoring severe dysmenorrhea can delay diagnosis of underlying issues like endometriosis. Next. Taking painkillers for periods is harmful and addictive. This is what usually the mothers say. So they are not very happy to give any kind of medicine. So we should tell them that the painkillers like mefenamic acid and ibuprofen are safe, effective when used appropriately. They are first-line treatments as per all guidelines. Then girls should not exercise during their periods. This is a very common myth and they are made to take bed rest. Exercise rather improves circulation, reduces cramps and helps the mood. There is no reason to restrict physical activity unless the pain is severe. Myth is there that periods should be hidden, and discussing these pain and periods is attention seeking behavior on the part of the girl. We should encourage open dialogue, reduce stigma, and encourage health seeking behavior. Pain should be acknowledged and supported. Next. This is a very common thing. Using hormonal pills like COCs at young age can cause infertility or heat in the body. The mothers say, "ये तो गरम दवाई दे रहे हैं आप." So we have to reassure them that hormonal therapy is safe, effective, does not cause infertility. It reduces endometrial thickness and pain. Home remedies alone are sufficient. We should tell them home remedies like hot water bottle and dietary measures can help. But in case the pain is moderate to severe, then medical therapy is definitely required. So what's new in dysmenorrhea? There are recent developments and shifts in practice which are there in various guidelines. There's a global push for menstrual health rights where WHO and FIGO take dysmenorrhea to be the part of universal health coverage and adolescent rights. Non-hormonal therapies are now under evaluation, and omega-3 fatty acids giving off magnesium, vitamin B and D are being studied for modest pain relief in trials. There is a shift towards early detection of secondary causes. This is very important, as ma'am also mentioned. Guidelines are reiterating that we should not be waiting for years before considering a diagnosis like endometriosis in teens. Ultrasound and MRI protocols are being updated for early, less invasive imaging. Then the use of AI-based tools for period tracking. And for India, FOXY and NCRT pilot programs linking school health clinics with menstrual education modules. Go on to the next, please. So what else can we do when a patient comes to us with her parents or her mother with dysmenorrhea? Of course, with menstrual education and menstrual screening has to be done, nutritional and lifestyle advice. What else can be done? Very important. We should be talking to them about HPV vaccination and encourage them to also take a dose of MMR vaccination and Tdap. Then parent education, mental health check-ins, these should also be done. And each visit should be a gateway to holistic adolescent health. So going to the last two slides, which are the key take-home messages. So painful periods are common, but not always normal. Persistent or disabling pain warrants evaluation. Start simple, treat early. NSAIDs, lifestyle changes can prevent escalation of symptoms. Use structured tools. HEADS classification for psychosocial assessment, menstrual diaries, guide holistic adolescent friendly care. Recognize, just go back please. Recognize red flags early. No improvement with first-line therapy. Think secondary causes. Menstrual health is a public health priority. Empower our adolescents, parents, and schools with the right information. So closing thoughts are, let's stop telling girls to be strong. Let's help them to be pain-free. Let's move from silence to solutions, from shame to science. Acknowledge the pain, empower with fact, and treat with empathy. I thank you for your patient listening.